the world nowadays is very small. We can see each other.
Yeah, even we are from different places and then it is very far. We can meet in one room.
Yeah. Only one thing that I miss from Samarang is ayam.
Ayam goreng and also lumpia.
Yeah, ayam. Yes.
When were you in Indonesia, sir?
Oh, I've been there almost every year.
Oh, I see.
Every year.
How many times, Dr. Farid?
Now more than 5 times.
Okay.
Yeah. I'm in Samarang.
Rajan
And I
getting very
also,
familiar with the Semarang, with Jogja, many Surabaya also.
Okay.
yes. And I expecting to return again. However, what's gonna happen? Because
we have to rest at home. We have to enjoy our home.
Yes. I was in the, for example, last year I was in Bali for 4 days.
4 days, yeah.
And then I have a plan to visit Jakarta and Surabaya. But because of COVID-19, I could not come.
Oh, so you haven't been in Yogyakarta then?
I've been there once,
all right.
a long time ago.
Okay.
However, I expect to come again, but because of COVID-19.
So have you been to Universitas Indonesia?
Yes.
Okay.
I and Dr. Farid, we have some class at Surabaya. Years ago, maybe. Or 3 years, I can't remember.
3 years ago.
With Pak Luffy, right?
Pak Lutfi, yes, with Pak Lutfi.
Yeah, with Pak Luffy. The world is very small now.
Yeah, that's true. We have gathering, some from Paris, some from Perth, some from California, Manila, Oman, wherever, overall all the world.
Yes, good. Very good.
Nur? Ya, bisa kita mulai?
Ya, silakan.
Okay, I think we will start soon this meeting. Okay, good morning. Selamat pagi everyone. I think we will
good morning.
Yeah, very good morning all participants in this good occasion. Now we will start the workshop for this morning. Good morning, Ajan Yotin. Good morning, all ideas. And also, good morning, Pak Nur Jasuli, as the Vice Dean of Academic Affairs. And
good morning, Mr. Farid and all.
Also, good morning, Bu Ati, as the Head of Department of the Biostatistik and Population Study.
Good morning.
In this occasion, we will go with the workshop entitled Direct and Indirect Method on Mortality in Case of COVID-19. This morning, the lecture and the workshop will be presented by Associate Professor Yotin Sawanggi. Very good morning, Ajan.
Yes, good morning. How do you do?
Fine. everything is fine. Even the COVID cases is still getting high.
Yes.
Before we start the meeting, I will invite Pak Nur Jazuli as the Vice Dean to give speech. Oke, silakan Pak Nur Jazuli.
Hello.
Yeah.
Can you hear? Can you hear?
Okay. Yes.
Okay, because there's the connection, internet connection is not stable. Although now I am in an office, at office. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
For the first time, let's we pray to Allah Subhanahu wa Taala. This time, all of us given healthy, and we can do this agenda as good as possible. Second, once again, I said to Associate Professor Yotin Sawangdi, PhD, thank you very much for your time. I think you give us, all our students, other good experience about direct and indirect methods on mortality in case of COVID-19. So once more, I say thank you very much for your giving knowledge and experience to all our members in Faculty of Public Diponegoro University and others. The second, I say thank very much to Mr. Farid who had organized this meeting. As we know that this meeting is a part of the world-class university program with the title Visiting Professor. We have some activities related to visiting professor, which would be held by other department in this faculty. The next, I say thank you very much to all participants, our student from Indonesia or overseas. Last time I say from Thailand and from University of Indonesia. Thank you very much for your participation, and I hope all participants will follow this meeting till the end of this time. May what Mr. Yotin give us will enrich our knowledge about COVID-19. The last one, I say apologies our dean. Really, he will give speech in this meeting, but at the same time, our dean have the same agenda in the university, so he cannot come together with you all. So once again, apologies him because not coming in this meeting. I think enough for I say too, and in the name of Allah Subhanahu wa Taala, and with permission of you all, I open this meeting by Bismillahirrahmanirrahim. Okay, I think enough, Mr. Farid. Time. I back to you, please.
Okay, thank you very much, Pak Nur Jazuli, for welcoming all of us in this morning. Before we continue with Ajan Yotin, let us see for a while the profile of Faculty of Public Health.
Ooh.
Ada suaranya Pak Farid ya?
Ya, suaranya nggak kedengaran. Okay, thank you very much, De Eko. I would like to inform you that in this summer, we have the summer course and it is totally free for all the participants. I hope that maybe Ajahn Suni, Ajahn Yotin, you can send your student to follow our summer course. I will send you the flyer for the summer course. And also we plan to have the international classes maybe for next year academic. Okay. Good morning for our audience. Before we go to the Ajahn Yotin, I will read a little bit about the curriculum vitae of Associate Professor Yotin Sawangdi. Ajahn Yotin, we call it like that to make it familiar. We don't call Associate Professor, it is too formal. Maybe for Thai people, we like to call Ajahn Yotin. Ajahn is professor. Ajahn Yotin nowadays is already retired, but he is still in the adjunct in the IPSR, Institute for Population and Social Study, Mahidol University. He was graduated the PhD from the University of North Carolina at Chapel Hill, USA. Nowadays, the Ajahn Yotin also gives the courses in multivariate analysis, mixed method for PhD, for master degree, and also gives some courses. The area of competence of Ajahn Yotin is the sociology perspective and also the nanotechnology impacts about poverty, migration, socioeconomic development and mortality, and also some data collection training. Okay, let us welcome Ajahn Yotin. Ajahn Yotin, the time is yours. Please give your speech. Thank you.
Yes, Sawadee-krap. Good morning, everyone. I'm very happy to have a chance to come to Samarang again, but not by plane now, by a very powerful electronic, Let's talking about the coronavirus and some idea about estimation. And the thing that we will discuss together is about direct and indirect method on mortality in case of COVID-19, which is the very interesting topic that Undip provided this for me. Speaking about the disease, I believe that it's not necessary for me to explain to everyone. People know about this disease very well. However, speaking about the idea to estimate and calculate mortality, data and information of COVID-19, in fact, we rarely have general information because of most the countries, they provide only the total amount of number. For example, how many people who have been infecting, from the disease, how many persons in the hospital, how many who have died. But cause of death, sometimes they're saying that besides COVID-19, but also heart disease, high blood pressure, and some other what we call chronic illness. Therefore, it is very difficult to calculate and estimate, such as a specific death rate, a specific mortality rate, or the projecting some cohort, some gender differential, some place of residence, if we want to focusing on are there any social gap on healthcare and potential to prevent, so that contribute to the thing that we need to understand how to estimate direct method. Before we moving on to the calculation, I would like to share everyone about World Health Organization coronavirus disease weekly epidemiological update. And the latest version is the August, the very last day of August. And let me scroll down to the table that I believe that everyone understand quite well. For example, this one, they divide the area into country. Let's look at South Africa. New cases in last 3 days is about 15,000. Cumulative cases is about 672,000 and some. Interestingly, new deaths in last 7 days is about 994 cases. At the same time, cumulative death is 13,981. And they also provide cumulative death per 1 million population is about 236. So that from this information, it's very nice that we're able to focus on every country. That is Africa. Let me go down to Southeast Asia. I think you may refer to look at what's happening in our ASEAN country. Look at Southeast Asia, Thailand. I need to go up to the very first column. Thailand, number of deaths is 58. Number of those who were cumulative number is 3,411. And I think number of people who were within 7 days is 49. These are persons who landing from overseas. Now let's look at Indonesia. Look at this, it's a huge number. Okay, so that WHO and most of the country, they're having this kind of information. As a result, the thing that we able to calculate, such as COVID-19 cause-specific death rate. And the formula is the numerator is number of deaths because of COVID-19 during the year that we focus on. But we have not having 12 months information yet, okay? At the same time, even if we have the mid-year population, okay, even if we have the mid-year population like the last of July, but we need to wait number of deaths because of COVID for year 2020. As a result, to calculate the cause-specific death rate, it is quite early to conclude what's happening with the disease. However, you can use this formula, okay, if you want to calculate with some specific of time. And mid-year of population, we can assume from last year or even if this year, but the calculate is a little bit underestimate. The result, everyone need to concern that our estimation still underestimate. Importantly, number of deaths we able to receive from the hospital or from registration only. For example, speaking about some developing country, not only Thailand, Indonesia, Cambodia, Laos, or any nation under the Southeast Asia. But if we consider Africa or any other region, they may having some trouble with healthcare and development. Some person, some community, or some area that quite remote, there may be some people who die, particularly those who used to work in town area, in urban area, and return home because of, at the very beginning of the pandemic, so that nobody knows. As I mentioned, to estimate the risk of, affecting by coronavirus, for nowadays, I would say that it is difficult. At the same time, we need to concern about the underestimate number. Besides the method, it is important, to understanding a specific death rate because of the disease. A specific death for particularly the coronavirus is very important. For example, in Thailand, I always receiving some message that people who die at the very beginning of the pandemic is the elder person who were above 60 years old. During August, we found that there are some labor force age. However, not many young person like teen or school age, children having this disease. As a result, if we want to estimate a specific death rate, by using the numerator is number of deaths because of COVID-19 in that specific age group, were mid-year population of that specific age group, this one. The formula is great, allow us to estimate, but the data is not available. As a result, it is quite difficult for us to provide some paper for publication. I focus on some manuscript from journal, and I learned that most of them talking about, vaccine, most of them talking about the situation of the country without presenting the cost-specific death rate, without talking about a specific death rate. So it's confirmed that, not many scholars receiving the data. And I'm wondering that some government may do not want to report to the public, not allow any scholars to estimate and calculate. not allow anybody to estimate live table from some data that they have had. Next, the estimate of risk about coronavirus. As you may know, we always talking about social role, comparing between male and female. Male, sometimes they may prefer to enjoy their life, the night life, the evening life, go to club, bar, many. At the same time, women may enjoying with shopping, go to shopping mall, go to some area that have highly population density. For this reason, there are some formula that allow us to estimate COVID-19 male-specific death rate, and the numerator is number of male deaths because of COVID-19 in that specific age group. See that this per 1,000, you able to observe, the 1,000 or 100,000. It depends on the size of the population that you would like to observe. So in general, we normally using 1,000. I think this is the common thing that person who were working with demography, sociology and demography, and sociology and development, like myself, we already know this kind of thing. Well, looking at the COVID-19 female-specific death rate, we certainly need to have number of female deaths because of COVID-19 in that specific age group versus mid-year female population of that specific age group. This is just an example. So when we look at this again, when we look at this again, you can see that the information that allow us is quite limited. So nobody able to produce the manuscript if we prefer to using, the concept of coronavirus and demographic pattern. For this reason, I would like to open the floor to discuss about data and information if we want to estimate by direct method. Please. You can share your idea, you can share your data. Yes. Not just only listen to my experiences. We will let you know about 10 minutes. Anything that you would like to share, please?
Oke, partisipan Bapak Ibu sekalian bisa share data, bisa kita diskusikan di sini. Ajan, actually I have the data of COVID in Semarang. Maybe later I will show you the data after your speech, and then I will show you the data from COVID-19 in Semarang.
You have age, gender, marital status, place of residence, or anything with you?
Yes, the problem is the data that published by the government. It is not the raw data. It is only the number of cases, the number of who are already getting better, and also the number of sex and race. It is the cumulative data, not the raw data. So it is a little bit, maybe the task force, they have this data, but for the general people, for the public consumption, they already put only something that are general.
Wow, that is great. So the thing that I would like to share is that everyone need to consider it live table, It is about the close population. So if we able to estimate a specific death rate, we, as a consequence, we also, able to calculate, the probability of dying and survival probability. These are the main thing. So from information that I get from Thailand website, at the same time from the WHO, I only able to calculate, cause-specific death rate to focus on a specific death rate, male-specific death rate, and female-specific death rate of the disease. I couldn't do it. I expect that some of our participants here, if you have data, it will be very wonderful for you to provide a manuscript and sending to some international journal, such as ISI, journal-based International Science Index, Scopus, PubMed, or anything. They always, asking about, are there any, direct method, particularly estimate risk of the person under the demographic direct method. This is important. Okay, and the calculation method is very simple, but the data is the most. All right. So that you are allowed to take photo, or in fact, I think Dr. Farid can share the PowerPoint for everyone.
Yes, we will share this PowerPoint after the meeting.
Now, talking about quality of care and prevention potential. This is also the direct method. We able to estimate, coronavirus or COVID-19 case fatality rate, such as the numerator is number of deaths because of COVID-19 during that time period per 1,000. And the denominator is number of COVID-19 during that time period. Okay. Look at this. Let me move up this kind of thing. And then I stop share and then sharing this kind of information. Okay. From here, we are able to look at the data. This is just an example. Okay. See, this is just an example. New cases in last 7 days. Okay, this one, new cases in last 7 days, such as in South Africa. Okay, and cumulative deaths. Okay, cumulative deaths. New deaths in last 7 days. Okay, new cases in last 7 days mean this is the number of new cases who were having coronavirus infection. And this is the number of deaths within 7 days. We able to use this number from the WHO report to estimate case fatality in this country. All right. So that under some limitation, but they allow us to estimate by using direct method. But we need to compare, country by country. At the same time, we need to provide another column such as GDP per capita of the nation. Because of the GDP per capita allow us to concentrating on macro level economic development. And we may providing some information about healthcare indicator such as number of health personnel, number of medical doctor per 10,000 population, number of nurse, number of whatever that we able to discuss. This is just an example. Okay. So any person want to share the idea, we will working and talking and discuss like this. I will be the person who stimulate your idea, and then be able to exchange I'm very happy that Dr. Farid mentioned that he having some data from Indonesia, but for me, I cannot have any socio-economic information from my country. I can use only data that I present to you. That is the WHO data. All right. Any idea that you would like to share? Or any? Yes.
I will share the data.
Yeah, please.
The data is in the graph again, not the number.
Yeah, please. Yeah, let's share data now. We can help.
This is the data. The audience, can you see the screen that I shared? This is the data from COVID-19 from Indonesia. This data is grabbed from the Coronavirus Task Force of Indonesia. We can see here, this is the cumulative data. We can see here the COVID-19 positive is still getting high, but in another side, they are already convalescing, they already sembuh, also getting high. So it means the prevalence of death rate is getting lower. You can see here the death rate is very low in here. If we compare this data to the cases of Central Java, the cases of Central Java, I don't know why it is the trend is like this. The COVID-19 is getting low, but you see the graph of the someone who are already sembuh, it is up and down. It's up and down like this. But we can see the trend of the death rate. The number of death is also getting low. If we compare the data to the Semarang, we can see here the red one. The red one is the dead one. The delay is getting lower, but the cases is still getting high. Even we have like pembatasan kegiatan masyarakat, it is some kind of soft lockdown aja. We have 1, 2, 3, 4, 5, 6 session of lockdown, but it is not lockdown, but we only prohibited some activity that very large people. So we prohibit for the meeting that have large people. We prohibit it, but we can see here the number is still getting high. The death rate is getting better. This is the data of Semarang.
Yes.
Thank you, Ajahn.
Yes, this is great. This is very good. However, WHO and every country, using this method, like presenting the current situation, calculate number, but do not presenting the situation under age group and under gender perspective. At the same time, do not providing place of residence or rural urban. Importantly, speaking about marital status, it is very important. It's telling us about that person stay alone or stay with family. Are there any interactive activity that he or she able to connect or spread over the disease to their family member? So that we really want to having some socio-economic, demographic information. As a result, be able to estimate life table and any demographic information that I mentioned earlier. You know, the information that you having present a moment ago and the information from other country around the world that I have been focusing on is the same. Anywhere presenting the trend, anywhere talking about is increasing, and but not having or presenting the demographic information. Okay, now let's look at this information again. Let's look at this information again. Look at the COVID-19 proportionate mortality. We are talking about quality of care and prevention potential. The case fatality, as I mentioned, we are able to calculate from the visual data, right? At the same time, the coronavirus proportionate mortality is the other thing that we able to calculate because of the numerator, the number of deaths because of COVID-19 during that time interval, and the denominator is total number of deaths from all cause during time interval. See, for the proportionate mortality, frankly speaking, it is the what we call coronavirus mortality ratio. See, the numerator is number of deaths because of coronavirus in that specific of time. This is the number of deaths, right? For example, in Thailand, this can be 58, okay? This can be 58 cases. This can be 58 cases, okay? Can be 58 cases, okay? We having about 58 cases die because of coronavirus. And the denominator is total number of deaths from all cause during that time interval in the same time. For example, you know, the number of deaths like accidental plus heart disease plus dengue fever plus malaria plus diarrhea or whatever. This is like a total number, okay, something here. So that you can see that COVID-19 proportionate mortality in Thailand should be very, very low. Okay, should be very, very low. So for the United States, you know, for the United States, I also bring some number from number of deaths because of coronavirus and total number of deaths from all cause at the same time period. I also learned that the coronavirus proportionate mortality in the United States also low. Surprise, also low. But I do not have that number here because I lost my calculating, piece of paper. But I able to tell everyone that COVID-19 proportionate mortality able to calculate, you know, from WHO information because we able to receive number of deaths from each country. At the same time, we need to work hard to look for number of deaths from all cause at the same period, okay, at the same time period. For example, in Thailand, Dr. Farid and I may concentrate during the Songkran period in Thailand, such as 13th of April to 17th of April, okay, under the total number of deaths of any causes at the same time period, this one, okay? So that this kind of calculating method can help us, but we need to working hard to look for the data, okay? So that some person mentioned that coronavirus is not dangerous enough when comparing to
Adjust your microphone.
I'm very sorry. Okay.
It's okay now. It is okay.
Okay, I'm sorry. Okay. Let's see. Okay. Let's talking about the coronavirus proportionate mortality. Okay. The numerator is number of deaths because of COVID-19 during that time interval. Time interval is during that specific time that we provide versus total number of deaths from all cause during time interval. For example, in Thailand, okay, if we focus on the coronavirus number of deaths between 13 to 17 April. This is the Songkran Day in Thailand, water festival, okay? And total number of deaths from all cause during that time. From all cause, this including, accident, high blood pressure, heart disease, diarrhea, pneumonia, or anything multiplied by radic or 1,000, okay? So that we able to say that the mortality ratio or COVID-19 proportionate mortality in Thailand is quite low. At the same time, if we concentrating on the United States, the numerator is number of deaths because of coronavirus is equal to some number, but we need to look at some specific of time. I mean, the time that we focus versus number of deaths in the United States during the same time period. This is the all cause of death during the same time period. Okay. As a result, we may conclude that COVID-19 proportionate mortality in the United States, is not high. Prevention potential of the nation is quite good. But if we look at the total number that the United States present every day, we may nervous due to it increase sharply. Not only number of persons who are having the disease, but also number of those who die. However, if we consider it on total number of the United population, at the same time, if we focusing on the total number of the American, either black, white, or yellow, and Hispanic, who were having some disease such as heart disease, pneumonia, diarrhea, or whatever, and we calculate COVID-19 proportionate mortality of that nation. Finally, we able to conclude that, oh my gosh, quality of care and prevention potential is quite good because of the rate is quite low when comparing to 1,000 population. Okay, so that it is challenging for us. I mean, for us means it can be you guys, everyone, including myself, to writing some paper together. Because of, even if the data is quite limited, but we able to use information, not just only the report about COVID-19, but we need to collecting data about other cause of death from the same nation, from the same time interval. Okay, what do you think? What do you think? For example, Pharma, Rina, or Ajahn Suni, including with Dr. Vishayapon and Dr. Farid and anyone. You are able to work in group like email, and sending email, sending data and exchange. We having some division of labor. Some people may collecting data about COVID from their nation. At the same time, another person may looking at some data about all cause of death. Then we able to calculate using some socioeconomic information such as GDP, population growth rate, import-export information providing table, as a socio-economic development under the macro level, so that we may having some beautiful manuscript sending to journal rather than waiting for some a specific death rate or cause of death. I don't know for I like male specific death rate. This is just an idea to share with you. Since we having some direct method to estimate, we rather using this advantage to write a paper. Let me show you again, okay, about the formula. Okay, so that to estimate, to estimate the quality of care and prevention potential, we able to use case fatality rate. At the same time, we able to use proportionate mortality. The keyword is COVID-19 versus all cause of death, but we have to providing specific of time that we observe. Okay. Any question? Any comment? Any idea to share? Now, the workshop is quite quiet. You guys prefer to be
very quiet.
rather than,
For everyone, you can ask to Ajahn Yotin something about this method. Please be free to ask directly.
Yes. My purpose is speaking about COVID-19 information. Okay, speaking about COVID-19 information. The data is quite limited because of most of the country provide the number. Okay, cumulative number of people who having infected by this disease, number of deaths, but do not giving gender, age information. Okay, as a result, we cannot estimate via a table. We cannot estimate a specific death rate. Okay, but I think, for example, those who working with coronavirus team, coronavirus prevention team, they having the data. Some medical doctor, they may writing some report to the prime minister or to journal. I have no idea. But for a person who
for the corona team's task force, they have this data. But the problem they do not publish. But maybe as the academic, we can recast this data. Little bit difficult. Little bit difficult to recast the data.
Right, they may wondering about security, and they may wonder about what we call quality of care and prevention potential method. They may wonder about some secret. I have no idea.
Security issue, Ajahn. They say that they have the security issue about this one.
Yes, security issue. Right. And it may related to investment, like a export import business, investment. Like a person from outside country may worry and wondering if they come to do some investment in the nation. Any nation, they may wonder, oh my gosh, labor force is have highly risk to coronavirus. The company need to pay a lot of service, a lot of facility, a lot of welfare to support. Okay.
And
for example, I'm gonna say that, for example, if Dr. Farid and I, including Rina and Pharma, writing a report about a specific death rate of COVID-19 in Thailand comparing to Indonesia. And Ajahn Suni may focus on the situation in the most southern province, comparing to the whole nation of Thailand, comparing to Semarang and the whole Indonesia. providing a specific death rate, providing male specific death rate, female specific death rate, so that there will not be any secret. Investor from abroad looking at our paper, he or she may nervous and say that, oh my gosh, labor force in this area is quite highly rich because of COVID-19. I rather reject or jump to the other place because of most of everyone is, not healthy enough. I rather need to pay a lot of money. Let's go to the area. This is the idea. So I think that, security is very important now. Okay. Now, if you guys still quiet, I rather open another formula. Okay. To estimate quality of care and prevention potential, the other formula that we able to do is COVID-19 death to case ratio. Okay. COVID-19 death to case ratio. In fact, the formula is death to case ratio. Okay. The method is, the numerator is number of deaths because of COVID-19 during that time interval. The word during that time interval, it can be during that week, during that month, or during that semester, or during that, quarter. If we divided time into 4 quarters, quarter 1, quarter 2, quarter 3, quarter 4. This is for example. Okay, per 100,000, per 100,000. And the denominator is number of new cases of COVID report during that same time interval, the same time period. Okay. Let me stop share and change to the WHO report. Okay. This one. Okay. I think everyone able to see this. Okay. New deaths in 7 days, South Africa, right? New death in 7 days is 994. Okay, per 100 per 100. And new case in last 7 days, this amount number, okay, 15,506. All right. As a result, okay, you can calculate this number. Okay, you can calculate what it is the COVID death to case ratio. Okay, so if the number is high, okay, if the number is close to 1, okay, if the number is close to 1, it means that highly risk quality of care is not so good. Okay, if it close to 1, I mean, people who the new case is 100, the death is 100, so 100% die. It means that the quality of care, prevention potential is not so good. Okay. However, if the number is lower than 1, is that correct? Lower than 1, it means what? Great. Is that correct? It means that great. If it's lower than 1, it means great. Okay. If it 1 and above 1, it means that, oh my God, prevention potential quality of care is not so good. The Thai government tried to use this COVID death to case ratio to present that the system, I mean healthcare system, not only the provincial hospital, the general hospital, and health promotion hospital in the community area, village level, sub-district level, including with village health volunteers who were working so hard in the nation. Okay, this kind of system, healthcare system and activity that we have been providing, including with social distancing and new normal activities, okay, it's providing a lot of support. As a result, number of deaths within 7 days, within 10 days, or within a week or a month in our nation is quite low. But when we focusing on the United States, okay, I also concentrating on this issue in the United States. Unfortunately, I cannot, bring the data from CDC, Center for Disease Control. They not allow aliens who were Thai to copy the data. And they just report.
They just read.
Yeah. Hello?
Yes, Ajahn.
Yeah, they, for the CDC, Center for Disease Control of the United States, most of the data that they provide just for American professor, for medical doctor in the US. So they mostly report under the graph, under the line graph, bar graph. For aliens like us who want to know their situation, we can look at only number per day, number per month, or cumulative number, similar to the situation that you have been presenting from Indonesia. Okay, so anybody who were working with coronavirus like myself under the demographic method or mortality estimation, we need to use the data a lot. Okay, but just only this kind of direct method, such as case fatality rate, proportionate mortality rate, death to case ratio can help us. Okay, but we have to compare. Okay, we have to compare economic, macroeconomic situation such as GDP of the nation, doctor and population ratio, nurse and population ratio, okay, population density, and cruise death rate from other source as well. Okay. Otherwise, the paper may not strong enough to publish in a very good, quartile journal, either ISI or Scopus. Okay, I try to initiate everyone to estimate coronavirus by direct method, because of that is the data that we can do. Okay, the indirect method is quite difficult. Okay, I will talking about the indirect method before we dismiss, but I just really want to listen from everyone. What do you think about the data that or formula that I present to you? That is the direct method that can help us to estimate coronavirus situation, to present our work and writing a very good paper by using some macroeconomic level information to help. Yes.
Okay, may I discuss something?
Yes, please, ma'am.
Yes,
okay,
please.
thank you. I'm Omas Bulano Samostir. I'm from Universitas Indonesia or University of Indonesia. I also teach about indirect method of mortality estimation, and I'm interested to attend your workshop because I also want to know about how to incorporate this COVID-19 pandemic in the estimation. And I also did calculation about the case fatality rate of this COVID-19, and I did every day. But my question is, which data should we refer? Because different sources will give you different numbers. Because sometimes I forgot, so if I want to get back to find the previous data for worldwide data, I could not find the same figures. For Indonesia, we have the data, daily data, and the cumulative one. and we can track back, but not with the worldwide data. I used to prefer to. May I share something? What I
Yes,
have
please,
done.
please.
Okay,
Yeah,
I
this is
will.
nice.
Yeah. Okay. Okay, I will send. Wait for a minute.
Yes, ma'am. This is
So,
the purpose of the workshop.
all right. Okay. I'm allowed to share. Yeah. So it is my data. First, I wrote from 1 April. This one is the confirm. The column C is the confirmed cases. This one is number of those who recover, and this one number of death, and this is the case fatality rate. Actually, I am interested with the case fatality rate. So 1st April and then 1st May, and then I continued with 17th of May, and then daily. So I mark with yellow highlight here where I forgot. So when I put the data, I could not find the same number from different sources. So this is my data. I just want to show that the case fatality rate decline. And this one, the blue one also, I put the sources, the WHO, and then all the methods. And then this is also the yellow one I forgot. So I put the source WHO. So it is for Indonesia. Okay, it is Indonesia alone. That one is worldwide. And then I did the same thing. And, I just want to show that the case fatality rate decline. And thank you for sharing that it is actually what you call as quality of care and prevention potential. And I want to share about the data. This is the data source I use for the worldwide. Worldwide, it is from this source.
From
Okay.
the Google, Bulan.
Yes, from Google. It is I will find worldwide from here. But for Indonesia, I will find from here. Wait, let me show. For Indonesia, I will find from here. Okay. Here is from Indonesia. Okay, so from kompas.com COVID-19. So I can see for, it is a total number, yeah. Since for the beginning like that, I can get the daily data, yeah, but not with worldwide, yeah. So the data I produce, come from different sources. I mean, not only from one source. So if I check, for example, yesterday data, I could not get the same number from different sources. So especially from okay, let me show you where it is quite make me confused, I'll share this one. Okay. For example, this is the number of those who recover. WHO reported 16,500 on the 2nd of September, but the Google is 16,700. And then for Worldometer, it reported those who recover is 18 million. So I said, which one?
Okay.
Which one should I? Which one should I?
Based on the.
Let me finish first. Let me finish first, please. Okay.
Yes,
So
yes.
which one? Because the one in yesterday data, it is still 17,900,000, but it's already 18.1. That's all my share. I hope we can discuss which data we should refer, whether WHO with detailed digit or which one? Thank you.
Yes, ma'am. This is excellent. Let me.
Thank you, Thomas.
Yeah, thank you. This is great. Let me explain to you. Before talking about the data that you have been using both sides, you are estimating because we are scholars and you and I using different terms. Looking at in my PowerPoint, I using case fatality rate. But for you, you're using like a case mortality rate. It's the same thing, like number of deaths because of COVID-19 during that time period, okay, during the time period, versus number of COVID-19 patients during the time period, okay, per 1,000. This is great. I learned a lot from your presentation. For example, this is months, right? This is month or time. Okay, starting from this time to this time. I found that from your calculation at very beginning, the trend is increasing. I mean, case mortality rate, okay, from your data is increasing. Finally, it's declining from 60% to 33%. See, it means that, at very beginning, number of deaths is high because of people don't know how to prevent themselves. At the same time, medical doctor and person who were health expert, just shocked because of this coming to our nation. Finally, after all, okay, the case mortality rate has been declining to 33% or something. It means that quality of care, including with prevention potential, has been improving, okay, have been improving. As a result, number of people who die is reduced. This is great. So I rather, suggest you to use the data from WHO because every nation need to sending that information to the office, to the WHO office. For data from other source, like internal information, sometimes, may underestimate. Okay, for me, I rather using the data that WHO report because every nation.
Excuse me.
Please.
Can we get time series data from WHO? How do we get that?
They give us only the table that I present to you. See, this is
yes. I already saw that this table before, but my question is, can we get access to the data from the beginning? For example,
no.
That's my problem.
No.
That's why
No.
I did not use this for showing the trend, but I did use this from worldometers for analyzing the different country differential. Thank you.
Yeah. Nice. Yeah, everyone.
Okay.
Yeah. Anybody want to share idea? Anybody want? Yes.
Omas, maybe you can get the data from the the University of MIT, Massachusetts.
MIT.
MIT from IT. MIT.
Worldwide daily data, yeah.
Worldwide, yes, they publish. They publish in the worldwide. They have the data.
Yeah.
They get from many sources.
Okay.
And also, I heard from maybe your university, Ajan, University of Carolina. They also publish the data.
We are not alien to them, yeah.
Yeah, they.
No, not the University of North Carolina, University of Maryland.
Maryland.
Yeah, Maryland.
Yeah, Johns Hopkins.
Yeah.
All right.
Johns Hopkins is the world center of.
Yeah.
Johns Hopkins is the data. Is the world center, but they collecting only for their purpose. However, information that they have been releasing to public just cumulative number. They do not
cumulative number.
Just only cumulative number. They do not given the 7 day, they do not given, quarter, they do not giving us a specific information, gender or anything. They're just showing. Okay.
Thank
you. To work hard themselves. They do not allow anybody competing them. I believe that. Okay.
They have the money, sir.
Yeah. Take it easy. Take it easy.
Yeah, we are alien. We are alien. We don't share the money.
Yes, but I'm very happy after learning that case mortality rate from Indonesia has been reducing from 66% to 33% roughly. Okay, so as I drawing the graph, the line graph, we able to conclude that quality of care and prevention potential of Indonesia is excellent, So I believe that sooner or later it may reduce to 10%. Okay,
now that currently is 41%, sir.
Oh, it's increasing, from 33 up to 41.
It declining. It is declining, but now it is 41 per 100,000 case.
Yes. Let me showing again. Okay, let me showing again. So
before you continue, they have someone who raised the hand. Maybe you can.
Please.
After this,
Yes, please. Yes.
Yes,
please. Bu Ati.
Yes. Thank you for this time. To Prof. Yotin, in Indonesia, that data COVID-19 is very, very difficult to get it. I want to know how condition in Thailand to get the data of COVID-19. So you can accurate information about COVID-19.
Yeah. Let me.
Maybe there is policy, special policy for get the data.
Let's see. For Thailand, I also frankly speaking, let me inform you a little bit. I have some former student, I have some former student who graduate from me and working with Ministry of Public Health, and she is at some what we call Center for Disease Control in some province. Besides, I also working with some medical doctor at Center for Disease Control. However, nobody able to go inside the data set because of it related to security purpose. Those who were the team that assigned by the Prime Minister can look at the data. But, to estimate a specific death rate, or gender specific death rate, calculating life table under some age group, estimating expectancy of the person who having COVID-19 by using multiple decrement life table. Okay, let me explain to you. In fact, I plan to talk about multiple decrement life table after the break, after the coffee break. but because you have been asking me about the data, let you know, for any kind of pandemic happening in any nation, life expectancy at birth and life expectancy at some age group is very important for any scholar to understand, because it's related to facility that we need to provide and serving the person who having the disease, such as, you know, what would happen if Ajahn Yotin, myself, having coronavirus? How many years, how many days, or how many months that I able to survive? As a result, the method that we need to use is multiple decrement life table. The purpose of multiple decrement life table is estimating not only probability to die, but also survival probability. Number of person who gonna alive, you know, and including with life expectancy at birth. Okay, so without that kind of information, without what we call age group, without gender information, without number of deaths of that particular age group, you know, we cannot estimate anything. We having only the mid-year population, okay, and the mid-year population normally calculating from, you know, estimation of population projection, understanding that this number is not 100% precise. Rather, it is better than do not have anything. But without a specific death rate, you know, we cannot do anything. Okay. Now
Yes.
let me. Yes, I'm gonna show you some data from Thailand. It is in Thai. However, it's very similar to your country. Okay, it is very similar to your country. Let me share you a little bit. Okay, let me share you a little bit. Wait a few minutes. Oh my God, what would happen? Oh, I need to come here. I need to come here. And then what? What happened here? A few minutes. A few minutes. What should I do? I want to expand this. Yeah, technique now. Technique now. Oh my God, technique. Okay, technique.
Technical problem.
Technique. I using Zoom a lot. Oh, now I learned it. I using Zoom a lot. But sometimes, you know.
You should have your grandchild there.
Yeah. Nobody married, ma'am. I have a son and my daughter. Nobody married.
No?
Yeah. I have the grandchild and he can help me.
Yes, that's what I did. Yeah.
Yeah. You see this? You see this situation in Thailand?
Yeah.
Yeah. The white one and number. You see it, right?
Yeah.
Yeah. The same thing. For example, okay. For example, cumulative number person who have been infecting by coronavirus is 3,444. This is on the 6th of September, year 2020, okay, at 9 o'clock in the evening, okay. 6 persons are new cases, okay, on the day, and 58,000 die, and the number 58 cases die. These 58 cases is the cumulative number since March, okay, since March, okay. Now, for those who were person who travel from abroad, okay, from abroad, okay, there are 506 cases, okay, having there are 506 cases come from abroad, but only 6 persons having coronavirus. And this kind of thing, this kind of people is under state quarantine, okay? And 424,545 here are person that we observing, so that the number that we have had in Thailand and any places are the same number. they do not allow us to see anybody. Okay, I mean to see any detail. Let me open again. Let me open the other. Let me open, okay, the other information. Okay, you can see here. Did everyone see this information? Such as ID.
Yes, yes, we can see.
Yeah, you can see they having the ID, age,
Age,
they didn't report, right? Sex, they didn't report. This is just the form, okay? This is just the form. This is just the form, So that I try to mention to my network, okay? People say that that is related to security. So you need to wait until we able to control, Now back to our, workshop. So before we having some coffee break or bathroom break, are there any question or anything that everyone want to share? Let's see. I frankly speaking, okay, I try to start with the direct method. Okay, I try to talk about direct method. Okay, let me repeat the possibility for us who were a person who focusing on demographic, sociology, and public health. Okay, for the direct method that we can estimate risk. Okay, risk related to coronavirus is COVID-19 cause-specific death rate. It is the number of deaths because of COVID-19 during the year. The pandemic has not about the year yet, but we can do for some time period. And the denominator is mid-year population, and this can be derived from population projection, and I believe that any country having this information, okay, mid-year population is not difficult one. Any country having it, okay. Next, COVID-19 a specific death rate. It would be nice if we able to have the information by age group, starting from baby until the very oldest age group, like 100 years old, okay? A specific death rate can help us to estimate life expectancy, okay? And here, a specific death rate, number of deaths because of COVID-19 in that specific age group versus mid-year population. Okay, this is simple, but we cannot have it because they do not release the age group. Besides, we can estimate male specific death rate, but we didn't have male information. At the same time, we able to estimate female, but we didn't have the female information. Okay. But luckily, WHO provide us, information that can estimate quality of care and potential and prevention potential. Okay, this one allow us to see the development of not only civil population knowledge, attitude, and practice to away from coronavirus. At the same time, it allows us to observing the quality of care from public health, like we having demand side and supply side. Okay, so case fatality rate allow us to focus on supply side. Okay, if the number is lower than 1, it means that prevention system is increasing. At the same time, knowledge, attitude, and practice related to social distancing, new normal has been improving. Okay. Now, coronavirus proportionate mortality, or we can say that like a mortality ratio. Okay, mortality ratio. You can see if the mortality ratio close to 1. Okay, if the mortality ratio close to 1. Or greater than 1, okay, close to 1 or greater than 1. It means that cause of death okay, that occurring because of COVID-19 is dominate your nation, okay, due to the total number of deaths from all cause is the denominator, okay. If this one equal or greater than, okay, or greater than, it means that COVID-19 is dominate the nation. Number of people who die because of pneumonia, number of people who die because of heart disease, number of people who die because of hypertension, number of people who die because of diarrhea or ischemic heart disease or dengue fever or diabetes may very few, but competing with coronavirus. So we able to writing this and this, but we need to work hard a little bit by collecting all cause of death. At the same time, we need to make sure that quality of our data from coronavirus is acceptable. As I mentioned this moment, only information from the WHO that we able to use, because of every nation need to submit that information to that organization. Okay. Now, before we dismiss, though, I propose the COVID death to case ratio, number of deaths because of COVID-19 during that time interval per 100 population, okay, versus number of new cases of COVID-19 report during the same time. And I mentioned, if this one equal to 1, okay, equal to 1, it's not good, it's not good. If this one, is lower than 1, it means that prevention potential quality of care is improving. Okay, so information from the visual table allow us to estimate this, but it would be nice if we able to comparing by nation under the socio-economic development indicator. Okay, we need to use GDP, we need to using some proportion between patient and civil population and nurse, civil population and doctor or healthcare indicator. Okay. So Dr. Farid, what do you think? Shall we having some break or any? Please.
Yes. Yes, Ajahn, they have a question about the formula, about the calculation from Puchahya. They have one question about the...
Yeah, please. Before having a break, please.
Yeah, after this we break a little bit. The calculation, the formula about the calculation proportion of death.
Yes.
Okay. What is the best denominator? It is all the cases of death, or especially only for the COVID. I think the previous this one for the second formula. For the second
one, right? The second one, right?
Yeah.
This one. Okay. Nice. Let's see. Let me. Okay. So that the proportionate mortality, okay, number of deaths because of coronavirus during that time interval. So you need to provide the time interval, such as the 1st of August, okay, the 1st of August till the 31st of August. This is for example, okay. And the denominator is total number of deaths from all cause. From all cause mean the summation of person who die, such as 10 people from COVID-19, plus 20 person from heart disease, plus 50 person from hypertension, plus 120, from accident, plus whatever here. Okay, this is the total number of deaths from all causes in that specific time period. Okay, so if the result here, okay, close to 1 or greater than 1, it means that dominated by COVID-19. Okay, it means that cause of death is dominated by COVID-19. By the same token, we able to conclude that, oh my gosh, prevention system, civil population knowledge and attitude, including with practice related to COVID-19 is not so beautiful, it's not so good. Okay, okay. So to calculate this number, COVID-19, COVID-19, we able to derive from WHO, from every nation. But total number of deaths, okay, everyone need to collecting from your country, okay, plus number of deaths because of coronavirus during the same time period. Okay. And as I mentioned, number of deaths because of the cause, normally it delay, it's about 1 year. It's about 1 year delay. All right. It's about 1 year delay. For example, I always using some vital statistics from Ministry of Public Health, concentrating on mortality in Thailand. So I try to estimate the years 2019. I have to wait about 2 years. Okay. The recent report is about 2018, for example. Okay. Any question? This is nice. This is a very nice workshop from my perspective, though. I think we can share, the way of learning.
I do have question, sir, but after break, please. Thank you.
Okay.
Otherwise,
yes,
otherwise we won't have any break.
Yeah. I miss Indonesia coffee, nah. Very nice coffee. Yes, I love it.
Ajahn Yotin very love the Indonesian coffee and also wedang uwu. That's something that little bit hot. Okay.
Yes.
For all participants, we will take a break for 10 minutes, Ajahn.
15 minutes better. I gonna see about 10 minutes or what? How about 11? No.
15 minutes.
15 minutes, and then we will come back.
Okay.
We
See
will,
you later. Yeah. Thank you.
Take a break for 15 minutes, and then please don't leave this room. We will back for 15 minutes. Okay, Ajahn, please.
Yes.
While we take a break, I will present the summer course from Faculty of Public Health. Maybe participant here, we can follow this program. I will share the picture. The summer course program for 2020. We can see here the requirement for the potential participant. First is the international undergraduate, graduate, or the student, and also lecturer. We found here to Ajahn from the south, from Yala and from Suratani. You can also join to this summer course. The time of this summer course is the 1st October until 10 October. So it is still next month. And also this summer course will be run by the MOOC, Massive Open Online Course. So you don't need to go to Indonesia. You can stay in your country and then following this program. This program is organized by Faculty of Public Health, University of Diponegoro, and for the enrollment for the final registration is on the 15th September. On the 15th September, before 15th September, you can submit to this information. The activity, including introduction to Bahasa Indonesia and introduction to the Diponegoro University, and also the main issue of this summer course is about the national health system in Indonesia, health community, factor control and strategy for the coastal Asia, community participation for the maternal and child health, participation in the controlling for the tuberculosis, community-based total sanitation, and also community participant in domestic waste management. And also, for the current issue, we also provide the information about the COVID policy and strategy in Indonesia, policy controlling, particularly in the Central Java, and also community participant and prevention and proportion. For this summer course, it is free of charge. And also the important things is that this course is equal to 2 credit point for the participant and certification. Okay, that's all from the summer course. I will share this flyer in the chat, and also we will send to you by email. And now we will listen to the department about the Department of Biostatistik and Population Study. And please, for all participants, please see the group of WhatsApp. You can find the evaluation for this meeting. This evaluation for this meeting, it is very important for us to measure the quality and also to see the participation activity.
Farid, I am back.
Yes, Ajahn.
Yeah, what do you think about the idea?
The idea, I can get it is very interesting to find or to compare, not to find, to elaborate some research, even the data is not detailed, but at least we can compare the trend of the COVID between country. For example, we compare the Thai and Indonesia. We can see that Thai already overcome this COVID very fast, only maybe 2 or 3 months. It is very fast. What is the policy there? And also we can compare to Indonesia. What is the policy in Indonesia? And also for the demographic side, we can see that the Indonesia is very huge number of population. So we can compare. Yeah, we can compare. What should we do with this population, the huge population? It's very interesting to find the idea about how to compare between the huge population and also medium population like that. I will stop my sharing. Did I still share something? No. Already stopped.
Yeah, if you want to. Yeah, I am sending the message because of, I think pharma or some person sending to me, I say that we need to use total cost of deaths from our cost from National Vital Statistic of the nation of the same time period to be the denominator. Okay, if we want to estimate if we want to estimate like if we want to calculate proportion deaths of COVID-19, what kind of denominator is a case of death or especially death case because of virus? No, it need to be a total number of person who die from our cause, okay? Try to look at the PowerPoint that I am providing and try to interpreting the result as I mentioned, sometimes the number is equal to 1 or greater. It means that not so well. Okay, it means quite dangerous and dominated by coronavirus. At the same time, if the number is close to 0, okay, close to, it cannot be close to 0, but lesser than 1, it means that it's improving, okay? It's impossible to be 0, at least some person die.
Yeah.
We have not started yet though, but let me showing this. I'm very happy that I can find my students such as Rina Pharma. They return home. They miss IPSR, I guess.
They miss the Friday market aja.
A Friday market, nah?
Friday.
Yes, I miss Halaya so much.
Yeah, you are almost done. I believe that. Try to work hard. I still working at IPSR because they allow me to work with them under the university employee until 65. So some more years to go. After that, they may, whatever is under the process, I have no idea whether I can work until 70 or not. Then I plan to move to another university. But let's see what would happen. Between now and then, anybody want to share idea or asking me anything related to direct technique? Okay, we understanding the direct method first because it's powerful. Okay, and anything is underestimation. You see, demographic technique, we focus on gender and age. Without information about gender and age, you cannot do anything. It does not demography though. Is that correct?
Yeah.
Yes, Ajahn.
Yes.
Yeah. We cannot do anything.
Yeah. The problem is how to get the data because it is sometimes it is closed by the government, only the task force who has the data.
Yeah. Let me exchange with everyone. Age is very important. It related to biological factor, of anybody, physical health. All right. Okay. Some person want to share something.
Oh, wait, Ajahn. There is something mistake here.
Yeah, your department. Oh, that's it. Yeah.
Maybe the sharing is delayed.
Yeah, that's it matter.
I will stop the sharing.
Yeah, let us go. I learn about the power. I learn about your faculty information.
Yes, Ajahn. You can continue.
Yeah. Let me exchange with everyone a little bit. We were scientists who concentrating on health, demographic situation, and everything. For me, I'm a sociologist, and my major subject is research methodologies, including with multivariate, including with big methodologies. We try to estimate number of things. Now concentrating on demography and biostatistics. Age is very important because of it related to biological factor, such as the baby, they were very young, highly risk to die or getting the disease. Comparing to the school age person who were 6-7 years old to 17, 18, I mean the youth or young adult, they were very strong and healthy. At the same time, when they were youth or young adult or late adult, they have been working hard and work outside home, having peer influence, having some good or bad health behavior, or habit, not so beautiful enough, eat, do not praying, exercise, or whatever. Okay, so that the behavior that they present, including with the work situation that surrounding their physical health, okay, can connect to some illness. At the same time, those who were elder person, the highly the age increase, the greater chance to weak. Okay, we call what frailty, frailty hypothesis. When you're getting young, you were having highly frailty. At the same time, when you're getting old, you were facing with frailty issue as well. As a result, without age information, we cannot estimate a very good number that can provide to policymaker, can provide to health expert to focus on and concentrating on which age group, which gender that we need to pay attention carefully for coronavirus. But nowadays, we just observing any age, okay? The situation that the WHO, including with any country, do not release age information, gender information, it means that they try to control and try to prevent everyone equal. Okay, I try to say that they try to make this situation equal, do not bias, because any pandemic happening, we need to treat everyone equal. We cannot, okay, bias or skew onto any age group, any gender. We need to block everyone and treat every person equal. There will not be any, social gap. Okay, there will not be any anything. But for us, okay, we have to measure. Okay, so the government or any nation try to treat equal. Otherwise, the pandemic will be greater and increasing and kill person. Okay, that is the philosophy. But for us, we need to measure whether the measurement, the thing that they're providing, are there any bias? Are there any age group? Are there any location or any area that need to concentrate carefully? Importantly, coronavirus not only related to population density, but also migration. Okay, but also migration. It related to like migration and health, migration and epidemiologies. Okay. So that population density is the place where they having the disease, but migration can link the disease, like a vehicle to bring the disease from this area to the other place. We need to talk about host and agent. For coronavirus, the person, human being is the agent. Even if there are some animals, such as, other kind of mammal can be the the host, but we concentrating on human rather. All right, anybody want to share? Wow, we have about 56 participants, big group, and 3 from Thailand. I mean, Yotin, Achan from Yatla, and the other are from
from Suratani.
Surat. Vichayapon, Surat.
Ajan, they have one question from our participant.
Yes.
Pak Dedi, please, you can ask directly. Pak Dedi, hello.
Yes, please.
Pak Dedi do not respond, but however, he already write down here in the chat room.
Oh.
Pak Dedi already. Okay, Pak Dedi, please, you can ask directly to Ajan Yotin. Please, Pak Dedi.
Okay, thank you, Pak Farid. We know that it is difficult to estimate the incline or decline of COVID-19 in Indonesia because of unsuccessful or successful social interventions such as lockdown policy, social distancing, masking policy, and others. How about Thailand experiences related to these issues? And also, we also doing some statistical modeling for COVID-19 with climate factors and also demographic factors. But we could not control the effect of social engineering or interventions in a statistical model because we don't have accurate information related to that issues. How about the Thailand experience related to the lockdown policy or social distancing, masking, and other social interventions? Thank you.
Oh, this is very nice question. Let me providing some information and discuss with you about some of my experience as Dr. Farid and the other Ajahn from Thailand may know that I have been inviting to be a guest lecturer for statistical class and multivariate course in some university for PhD level. We using Google survey. Okay, let me explain a little bit. We mean myself and my student from some university, okay? Related to the topic that you're raising, okay, it's the same idea that my student and I practicing in Thailand. We design the Google survey, okay, around the nation, sending via email, Google survey. I think people familiar with, okay? After that, the Google survey, and then the information on our Google form is about age, gender, education, such as socio-economic information. We don't know their name, but they report via Google form, okay? Like a socio-economic information, demographic information, age, occupation, whatever, marital status, including with, okay, information about knowledge, attitude, and practice that related to social distancing and new normal. It is under the scale information 5, 3, 2, 1. Okay, and some information we measure by 1, 2, 3, 4, 5, 6, 7. Sometimes 1, 2, 3, 4, 5 until 10. It's like a scale information to measure about their knowledge, attitude, and practice. At the same time, to measure about whether they are having some idea related to coronavirus or not. All right. And the information that we concentrating on is also having, are you living in urban or rural or semi-urban? Okay. Okay. The answer is nothing statistically significant. Listen carefully. Nothing in my multivariate analysis, either multiple regression, logistic regression, or negative binomial, nothing statistically significant. My student and I laughing, and we learned that this is because everyone practicing the same thing. Everyone following our government strategies, such as put on mask, washing your hand, okay, and social distancing when you're traveling by bus, by sky train, or anything. And this Google survey was about a month ago, okay, about a month ago. You know, it's a little bit complex. After we receive information from Google, we turn to Excel and then adjusting from what we call string to numeric. It takes time a little bit. Then we estimate by some software. I think Rina, Pharma, and Dr. Farid can guess what software that I'm using. And there is no statistically significant because everyone, you know, using and practicing the same thing. All right. And knowledge is average is about 7.5. I mean knowledge score. Yes or no look alike. Due to people practicing the same thing. Okay. Means average is look alike. That is contribute to no statistically significant. Finally, my student and I conclude that, oh, it's nice that Thai people following the government strategies. Yes, that's it. That is a month ago.
Thank you, Ajahn.
More than a month ago. Yeah, more than a month ago.
Okay, thank you, Mr. Yotin.
Yeah, you are very welcome. Okay,
Ajahn, now you can continue with, yeah.
Yeah, let me talking about the next slide. Okay, now we come to the indirect technique. Okay, we talking about formally we talking about formally. Okay, we talking about direct calculation when focused on the coronavirus. Now this time, okay, I try to explain about indirect method, okay? At very beginning, okay, this is just my idea. This is just my curiousness, okay? Let me talking with the multiple decrement live table, okay? I do not have the multiple decrement live table of Thailand here, okay? But you can concentrating on multiple decrement live table from this book. Let's see from this book, okay? This book, you may purchase from whatever, okay? I just want to tell you. The purpose, okay? The purpose of multiple decrement live table is to estimate probability of dying, probability to survive, including with life expectancy at birth and at some specific cohort. Okay. Multiple decrement live table allow us to estimate that kind of thing from some specific disease, okay, or some specific cause of death, okay. Before estimating multiple decrement live table, we need to receive or construct, okay, a bridge live table first, okay. We need to construct a bridge live table, okay. So when I'm talking about a bridge live table, I believe that everyone understands, since you were demographers or since you were biostatistician person, okay, construct a bridge live table is not difficult, but information that you need is age group, okay, mid-year population, and then number of person who die because of that specific cause of death. Or in this situation, we can say that about coronavirus or COVID-19. Okay, so we cannot, as I mentioned, I cannot even estimate via multiple decrement live table because I do not have age, I do not have gender. I have only the amount of total case, and I cannot using some indirect method to estimate what, how many coronavirus among 0 age group, I mean the baby, how many people who die between 1 to 4, 5 to 9, even if I have, what we call lump sum number or total die, I cannot distribute it. I cannot using Brass method. I cannot using any kind of method because those methods, provide for when we having each age group, when we having age group, at least some each age group, information. But coronavirus, neither Thailand or Indonesia or any country provide for us, except the United States, Johns Hopkins, they keep it for their purpose, okay? They release only the information that everyone need to understand about the situation, okay? Now, multiple decrement live table, okay? Multiple decrement live table allow you to estimate, okay? NPX, J is the cause of death. In this situation is coronavirus. P is survival probability. Okay, P is survival probability. X is the age. Okay, N is interval. Okay, you know that like a NPX, NQX. You know this very well. Not necessary for me to explain to you like a 1 to 4. Okay, 1 to 4 or 15 to 19 or 20 to 24 for myself. X is 60, N is 64. I almost 64 now, okay? This is just an example. But the purpose of computing this cost eliminate live table or cost eliminate method, okay? The purpose of cost eliminate method allow you to focus on, okay, probability to survive of individual. What would happen if we able to reduce, coronavirus from the world? Or what would happen if we able to produce vaccine for this disease? This is just an example. Okay. So I have some curiousness. My dream is what would happen, okay, on coronavirus probability. This one, NPX minus J. Minus J, in this situation, J is coronavirus, okay, COVID-19, okay, COVID-19. What would happen if we able to reduce coronavirus, okay? This one is NPX minus COVID-19, okay, minus COVID-19. What would happen, okay, if we able to erase COVID-19 from the world by using the vaccine? And we need to concentrating on each specific age group, like, like a super old. Super old means people who were 95 to 100 or 90 to 94 or 80 to 84 or 85 to 90. For me, I am the young old, okay, the young old. Other person may old days old. Other person may under between, okay. This is the formula to estimate or calculate, okay, probability of dying after reducing COVID-19, okay, eliminate COVID-19 and concentrating on the age group, okay. So the formula is probability of dying in general, okay. This is NPX here, probability of dying in general. This number can be derived from a bridge live table, okay. This number can be derived from a bridge live table. Rather, this number need to calculate from multiple decrement live table, okay. As a result, without number of deaths by age group, by gender, we cannot estimate anything. I have no idea whether people who were in North Carolina, in what we call Johns Hopkins, or even Chicago, Michigan, Wisconsin, these are the school that having a population center, such as the biggest and very famous one is Carolina Population Center, where I used to work with as the trainee. You know, when I was in school, I work in sociology, but I affiliate with Carolina Population Center to earn experience before I coming to my lovely institute, Institute for Population and Social Research. I have been working with, many scholars who were like, many people who were computer expert, biomathematics expert, who were biostatistic expert. I learned a lot from them, but they may having the data like age and sex information related to COVID-19 because of they were American. For us, we are Thai, we are Indonesian, we are any people who will listen to me, and we working with outside the United States. I believe that some government or some scholar who will work belong to the Prime Minister office, it would be nice if they allow us to use the data so that it can help policy planner to estimate about probability to survive. What would happen if if COVID-19 have been eliminated? This formula and this formula is the same thing. I just changed J to COVID-19. Okay. Now, to make everyone understand about, so I believe that everyone familiar with the word multiple decrement life table. Okay. So before I talking about computing risk or cost eliminate life table, I just want to listen to everyone your idea about multiple decrement life table. Are there any person know and used to use this multiple decrement life table? Before great, very good.
I teach students to calculate contraceptive discontinuation rate. We use multiple decrement life table.
Yes. Multiple decrement life table not only able to help us estimating probability to survive, probability to die related to a real mortality situation, but also drop out, family planning drop out, or employment or any kind. It is the method, but most of demographer, health expert, and biostatistic can apply to the other purpose. That is excellent. Yes, any person? However, okay, let me jam a little bit. However, before we estimating, multiple decrement life table, it is very important to estimate, a probability to survive by using information from average life table. Okay, it's like a step by step. Okay, and I try to focus that without age and gender information, we cannot do anything. It's just crude birth rate, crude death rate.
Or with contraceptive discontinuation rate, we have to know how long a woman usually use method. So that's what I want to know. How about this COVID-19? How long someone get infected or recover, or that is it like that? I'm thinking something like that. So it means that when we apply multiple decrement life table, we need time information, don't we?
Yeah, we cannot, because every nation they use some quarantine, right? 7 day, 15 day, and duration of observing in the hospital is depend on person, So
Excuse me.
Yes.
Is the life table that you mean is one of the survival statistic model?
Yes, we able to plot. Yes, we able to plot survival graph as well. Yes.
I think we can use survival analysis too and COVID analysis for research. Yes.
Yes.
And
Yes.
yes,
Go ahead.
in survival analysis, there are two methods, the life table and I forget one method again.
Survival analysis, right.
Non-parametric.
Non-parametric, right. There are numbers of, method that helping us to estimate probability to survive. Okay. At the same time, if we receive probability to survive, we able to estimate probability to die as well. Just 1 minus P.
Yeah.
Yeah, it's just such opposite thing. As a result, it's different. I mean, different technique provide us same output. So it depends on information that appropriate. Okay. Now, thank you very much, ma'am. And now the idea that I would like to talk and share with you is cost eliminate life table. Okay. The purpose of cost eliminate life table allow us to estimate, okay, probability to survive or survival probability when coronavirus has been extinct or we able controlling by applying some vaccine. Okay, we call coronavirus vaccine. Okay, so the idea is, let's see, NPX, okay, NPX here like a probability to survive of some age group, okay. The total is 1, okay, the total is 1. Probability to survive is starting from 0, okay, to 1. If you guys multiply by 100, it will be equal to percentage, okay. From this slide or PowerPoint, okay, NPX, a probability to individual to survive, okay, equal to the multiplication, okay, multiply like a NPX because of cardiovascular, multiply NPX or probability to survive due to cardiovascular, probability to survive because of neoplasm, probability to survive because of COVID-19, probability to survive because of the other cause, so that to estimate probability to survive because of COVID-19, eliminate, okay? To eliminate this, okay, we need to move, okay, this one, we need to move this one, okay? As the denominator, we need to move this one as the denominator. For example, okay, this one, okay, divided by NPX, okay, coronavirus, okay, and finally this one is according to divided by NPX, COVID-19 or coronavirus. We cut this, okay, Finally, the probability to survive after coronavirus or COVID-19 has been eliminated, mean this one, okay, will be equal to the probability to survive of the other causes as cardiovascular multiply with neoplasm, multiply with others. That is finally this one, okay, this one. This is the final formula. So that if you want to estimate probability to survive because of COVID-19 has been eliminated, okay, you need to calculate probability to survive from multiple decrement life table first. But in this situation, we cannot make it, okay? Even if we know the method, but we cannot make it because of we do not have information age and gender. That's it, okay? That's it. This is the idea that I would like to share. In addition, come to this one, okay? That is the cost eliminate method. In addition, okay? Okay, then we can discuss before we leave to our home country. The other indirect method that I think it is very important for COVID-19 or coronavirus is COVID-19 mortality projection. Okay, COVID-19 mortality projection. Okay, the purpose of mortality projection is estimating survival probability. Okay, still debating. For example, myself, who will travel a lot, not only within Bangkok. I mean, because I have some meeting in Bangkok, I have some meeting in some what we call university. I have some lecture in some area, in some, at the same time, I also travel by plane from Bangkok to Chiang Mai, from Bangkok to Phuket, from other places where having some PhD program and university. So I have some risk, okay? I have some risk. Still, people talking about Ajahn Yotin, you travel a lot. It seems like you have some risk. You understanding some mathematical equation? Could you please tell me about survival probability when everyone having COVID-19? 0 means 100% die, or 1 not death because not die because of we able to control. We have some medicine able to, concentrating on the effectiveness of this kind of medicine. Okay, so that survival probability related to coronavirus or COVID-19 is very important. WHO and other organizations presenting only the proportion to survive, such as there are this amount of number of person who having infection, and there are this amount of number of person who die, such as death ratio per cases, as I mentioned by direct estimate an hour ago. But this time we want to estimate survival probability, okay? So that the formula is this, okay? The formula is this. This is the formula, okay? This is the formula. NPX is probability, okay? Probability to survive, okay? Or survival probability of cause J. Cause J here is coronavirus or COVID-19, okay? At time T, time T can be next quarter, okay? I mean quarter 4, or next week, or next 7 day, okay? Next 7 day. This is the power, okay, at time T, okay? Next 7 day, on next 10th day, on next month, or on next month, okay? On next 14 days after having some disease, I mean, after having some coronavirus in your body. So you can say that, Thai government, okay, allow us to under the state quarantine for what, 14 days, such as some person who were landing at Suvarnabhumi Airport or Don Mueang Airport, they need to go to state quarantine, okay, area in Pattaya area for 14 days, and then following every days until they act that, okay, there is no coronavirus, okay? Or some person who may have some illness, such as some what we call a temperature above 37.5, is try to say that you were under some highly risk group, you need to under our observing procedure, okay? Okay. Now, to estimate, probability to survive of coronavirus at time T here, you need to have the probability, okay? You need to have probability to survive because of coronavirus at time T minus 1. For example, this one, the next 14 days, okay? The next 14 days. This T need to be 14 minus by 1, okay? And power by H here, This one is the camp, okay? Camp here. And then power by H here, okay? H is hazard, okay? H is hazard or hazard rate, okay? So that The method to estimate this H is this, okay? So I try to make simple, okay? Hazard is H equal natural log, okay? Log, this one is natural log. The log is equal to, this natural log is equal to 2.71828, okay? Log, okay? N P X J, NPXJ, okay, NPXJ, at time one, at time one, at time one, at time one here. At time one can be the next, the year before we estimate. Such time one means people die, okay. This is, for example, means next years, okay, means next year. And at time zero is mean that that person still alive. Zero is mean not die, one is die. Oh, okay, so that versus log N P X J, okay, at zero is mean that when that person not die yet. At time zero, not die yet. Time one is mean the next year, the next time. So that we we have to estimate this number and this number, okay? Now, using this H or the product of this formula to put power here, okay? Then we able to estimate the probability to survive, of coronavirus for the next day, for the next month, next time period, okay? Be able to conclude that if H, okay, if H here, okay, if H here greater than 1, hazard rate, okay, if H or hazard rate greater than 1, it means that that person or that age group having highly risk, okay, to die because of coronavirus, okay. At the same time, if H or hazard, okay, lower than 1 or close to 0, see, power to 0, okay, power to 0, where it is impossible, okay. NPXJ, okay, NPXJ, not necessary to estimate because nobody died. But in this situation, under the indirect method formula, we cannot estimate, survival probability because of COVID-19. It is because the limitation of age group and number of deaths due to COVID-19 because of that, particular cause of death, okay? As a result, at the same time, year here, or time here, we can change like last week to the next couple weeks. That this thing is just year. We can change year to months, we can year to week or whatever. And the constant is natural log. But the very important is, age group, okay, age group, okay, number of days by age group. This is the idea. I pick up cost eliminate, method. I pick up the indirect method under mortality projection because of I want to present to our workshop that demographic information such as age and gender, is very important to estimate any information about mortality in any places. Okay. Now I would like to share my idea. First, what would happen with with coronavirus if we able to develop vaccine? It means that the disease has been extinct. NPX or probability to survive still high or not, and what kind of cause of death that have strongly influence on that probability to survive? Is it because of cardiovascular, or is it because of diabetes, or is it because of neoplasm? This is for example, okay? At the same time, what would happen if we have number of deaths under some age group what would happen with probability to survive of that particular age group. Okay, this is just some challenging, and the reference is Smith, okay, formal demography, this one. I used to book, okay, to prepare the PowerPoint, formal demography, this one from David Smith, and this one, okay. So I believe that any place at any biostatistic department having this textbook, okay. Now, any question or any idea that people share with me, please?
Maybe the calculation a little bit
Yes, please.
difficult.
Yes, please.
Yes.
Yeah.
Yeah, which one?
I would like to ask a question, please.
Yeah,
Yes,
please.
Okay. Will you show an example? For example, like this, allow me to share about
please.
using the multiple decrement lab table. My question is about how to calculate using this method that I learned.
Yeah.
Like this, for example, we have, for example, 100 episodes of contraceptive use. So there is a time information. And actually, I'm expecting that we can have something like this with this for calculating the probability of dying of COVID-19.
I think this one you can use what we call survival analysis.
Yes. Okay.
Hazard model.
Okay.
Yeah. The pattern of your data is similar to longitudinal studies, right?
Yes.
Duration of time period, right? Follow you observing each episode, right? And you're able to apply in proportional hazard model. Yeah. You can use SPSS. I think version 18 until nowadays version can be estimated, but for proportional hazard, it's a little bit tricky. You need to prepare your data appropriate to that situation. It's a little bit not complicated, but tricky a lot.
Yeah, with Indonesia, demographic and health survey data.
Yeah, that is great. Yes. Dr. Farid is the person that you can contact to. He knows everything. Rina too.
Actually, our article was published in Journal of Preventive Medicine and Public Health in Korea. It is Q2 Scopus Index, and the SGR is 0.72 now. And we apply convert survival analysis for our model. Thank you.
Yes. Yes. Any person want to share your idea or asking question? It is fun.
Chanka, I would like to ask about the lab table. I believe that I suppose I want to calculate the life table, but the survival rate from the lab table, but I don't have a age specific data that specific data. So instead, I have data of daily death. Can I replace the age specific data with daily death?
Yes.
Yeah, the age specific.
Yeah, you can.
Okay.
Yeah, the answer is yes.
If that's so what is the possible recommendation that I believe we cannot recommend based on the age, right? For this, can you give me the example how we provide recommendation for that kind of calculation?
Yeah. Let listen carefully. Listen carefully. The purpose of a bridge life table is estimating the life expectancy. To estimate a specific death rate, the denominator need to be mid-year population. Is that correct? This is the way of life table calculating method. For you, the mid-year population need to change to midday population. You got the point?
Yeah.
A bridge life table concentrating on the year, big time frame. But for you, you're focusing on a day or a week or a month. You change unit of measurement of your time from year to day to a day. As a result, the denominator need to be what we call midday population, time. It looks unusual because I may die at afternoon, but you thought that Ajahn Yotin died at 11 o'clock. It is the way of mathematics and the way of calculation is fine, but sometimes journal or anybody who were very strong with mathematics, they may not accept the work. But for me, I say that you are able to do it. Okay, you are able to do it. You know, we are scientists, we can do whatever we having hypothesis, we able to test, okay? In this situation, a specific death rate, not mid-year population, you need to calculate by midday population. And number of people who die because of coronavirus or because of any cause of death, it need to be under that day. The idea is same specific time that we observe. Yes. Yeah, please.
Yes, maybe SPSS program can be used to analyze the survival analysis. Yes.
Yeah, right. Let me explain a little bit for SPSS. The function can help you estimating under the life table function. At the same time, what we call Kaplan-Meier method.
Yes, Kaplan-Meier, yes.
Yeah,
Kaplan-Meier is non-parametric statistic, yes. So we use a small sample.
Yeah, right.
Yeah.
And under Kaplan-Meier method, you're able to using log rank, okay, to estimate significant level to comparing the two by two table. Besides, you know, the very last function of FSS, you are allowed to estimating survival analysis under proportional hazard model. But the data need to be longitudinal studies or longitudinal data or panel data. I think your family planning information that is under longitudinal panel data, it's able to estimate, but it's a little bit tricky to providing data file.
Sir.
Okay.
Okay,
yes.
Thank you, Bu Ati.
Sir.
Yes, sir. Yes, ma'am.
About your last slide.
Yes.
I'm sorry.
Let me back to my slide.
I don't, not that one, the previous one.
Yeah, let's see.
This
one?
Yes, please.
Yeah.
I don't understand about this formula. Is it possible to write them with using?
Yeah, I have to
equation
here.
Yeah, using equation. With using equation, I mean so.
To calculate hazard or to calculate.
No. My point is the way you write this.
This one?
Yes. It is one formula, isn't it?
This one,
Yeah,
right?
This is one formula, isn't it?
Yeah, right.
Yeah.
It is this one. Look at.
I mean, it will be clearer if you use Microsoft equation.
Yeah, this one is like this. Let me show you. NPX, okay.
Yep.
NPXJ, J is mean cause of death, okay.
Yep, understand.
At
Yep.
time T, it's supposed to be this at time T, okay.
All right.
It will be far away. Nice.
Okay. Yeah. Okay.
Yeah.
This I understand. This one I understand,
Yeah.
but the one in the box I don't understand.
NPX now NPX, okay. NPXJ, okay. NPXJ, okay. At time T, but minus one.
Multiply by
Yeah.
by, and how about the hazard?
And then this product, okay.
Yep.
You have power by hazard.
All right. So the hazard is power, yeah.
The hazard is this.
The loan. Okay.
Yeah. Log is this amount.
Yes.
Constant. Yes. Natural log.
Actually, it is exponential, yeah. E. Yeah.
Yeah. Right. E. Right. E. If you want to remove log. Right.
Yeah. Not ln.
And this one is. Okay. Is the. Yeah.
So, what information do we have to produce the hazard? So we must have Bxj at time t minus 1 and time t. So which one we know to produce what?
Yes, okay. At very beginning, we need to estimate hazard first.
Okay.
By constructing, okay, listen carefully, by constructing, multiple decrement live table.
Okay, so we obtain the hazard from that.
No, we obtain probability to survive of cause J.
Okay, I see.
In the next year, okay, next year.
Okay.
At the same time, we need to obtain NPXJ of the year that person has not died yet.
I see. Okay.
Okay.
Yep.
All right.
My next question, sir.
Yes.
How do you do that? Is it what we call it synchronous lecture?
We
so you can
do this. I cannot do this because I do not have a specific death rate. At the same time, the reason that I cannot estimate a specific death rate because of COVID-19 is due to WHO and Thailand or any other country, they do not release age group, number of people who die by age group, number of people who die by different age. Okay, as a result, we cannot do anything. The limitation of demographic information such as age and gender by age group, is the obstacle for anybody, even mathematician, to calculate probability to survive, including with probability.
Understand. My question is how I want to teach like you, so I can write the formula. What do you use, please? Can you share with us? I never
the book.
No. Not the software.
The software.
Synchronous teaching. So you can you can write on your PPT. What do you use?
Let me explain to you. We use Excel. Okay, we use Excel. At very beginning, let me explain to you a little bit. We construct a big live table first by Excel. After we having that kind of information, I mean, number of people who die because of COVID-19 from each cohort, okay, but we didn't have it. This is just an example. We need to construct a big live table first. After that, after that, bring probability to survive from this life table to construct multiple decrement life table. Then bring information from multiple decrement life table to construct cost eliminate life table. And then information from cost eliminate life table to construct mortality projection in like step by step. We call multi-state life table. Finally.
Okay, thank you.
But you know,
I understand that. I did construct life table for Indonesia actually.
Yes, yes.
But actually, my question is, I'm sorry. How do you write those formula on your PPT? No, on your PPT.
The command, right?
No, the formula. I mean that we call it that synchronous.
Yeah, right.
Yeah.
Right, but for me, I am the old man, and I starting from a slide table and Excel step by step. Right. I have no idea whether nowadays we having any software to help or not. But most of us think Excel. Yes.
All right. Thank you, sir.
Yeah. You are very welcome. Yeah. Any person? Anybody? Please. It's nice to have a chance to exchange the idea about calculating, probability to survive, direct and indirect method that appropriate for coronavirus under this limitation situation. Okay, it's fun.
Okay, please, anybody, maybe they have some question or you want to share something about the mortality of COVID. Don't be hesitate to contact directly, to unmute your microphone. Or raise your hand. Or you can talk directly, please.
Pak Farid, boleh nanya dalam bahasa Indonesia nggak?
Oh, boleh. Silakan.
Sebenarnya pertanyaan saya yang terakhir, gimana cara mengajar pakai Zoom, lalu synchronous teaching gitu loh Pak, bisa nulis-nulis rumus di situ gitu loh. Pakai apa dia tadi? Dia ngeklik sana, ngeklik sini, lalu ngetik tulis rumus. Itu sih pertanyaan saya, pengen tahu supaya bisa mau buat ngajar. Terima kasih.
Oke. Jadi agak sulit memang kalau pakai synchronize untuk itu. Mungkin Bu Omas, mungkin bisa aja Newton saya minta untuk tunjukkan Excel-nya begitu ya. Aja Newton, maybe you can show a little bit about the updates.
No. I don't need that. What I do need is to know how our research person type the formula on the PowerPoint presentation on the screen using Zoom. I saw you clicking this, and then you type in. So that's what you call as synchronous. We use teaching online.
Right. Because of
That's actually what I asked.
Yes, right.
What software do you use? I saw you clicking, color.
Oh, writing, right? Writing,
yes.
right?
Yes.
I see.
Okay, now look at this.
Teach us, please. Because we will start.
Okay. Misunderstanding.
Okay, Ajahn Farid. Dr. Farid, please. Dr. Farid.
Yes.
To answer that question, 20 baht. Okay, I'm joking. Okay, look at this, lady. Look at this. Okay.
I am looking.
Okay. Come here. Okay. I come to my PowerPoint. Okay.
Yep.
So that you see my PowerPoint, right?
Yep.
You see my screen, right?
Yes.
Yep, I do.
And you see this cursor. You see the cursor?
Yep. Yes.
Bring cursor to this corner. You see the corner?
Okay.
You see the corner?
Yep, I do.
pencil. You see the pencil or marker, right?
Yep.
At the left-hand side, the very lower left-hand side. Did you see it?
Yes, I do.
Click it. Finally, the color come up.
Okay.
Choose what kind of color you want. For example, I prefer the red one. I just stick the red one.
I see. Thank you so much.
Okay.
Very simple.
Next time. Yes, ma'am. Next time you need to buy me a jam when I go to Indonesia. This is just thinking. Yeah.
It's okay. It's okay. Yeah.
Kidding. Thank you so much.
Thank you so much, sir.
Yeah, you are very welcome, ma'am. You are very welcome. Yes. I give you big hand, huh? Yeah.
Maybe another participant
Thank you.
Yes. Comment or something.
I want to know about the Thai participant, Dr. Suni and Dr. Vichayaporn. Are there any questions from us because we from Thailand? And as I mentioned, I try to do my best to help everyone, either Thailand or any person abroad. But the data due to related to security and importantly, the pandemic has not over yet, and we cannot develop vaccine yet. So that I try to estimate, cost eliminate, what would happen with probability to survive, what would happen with probability to die. We have mortality projection, but I can't, as I mentioned to you. It's challenge, but at least we're able to produce paper, macro level information and work on.
Kun Ajan Wichaya or Ajan Suni, you can give or you can share your experience on the COVID. You can share.
So we are lucky that Samarang and Bangkok we have.
Yeah, Kun Wichaya may share your experience. Kun Wichaya, please.
Hey, Ajahn Farid, your Thai is excellent, huh? he speak Thai เหรอ
สวัสดีค่ะอาจารย์วิชยาพรค่ะค่ะวิชยาพรทองเพชร in สุราษฎร์ธานี Hospital in Thailand. I learned PhD with Professor Don in research methodology in PSU Pattani.
Oh, Don McNeil,
yes. And I had experience in the COVID data in Surat Thani province, and I think some information and health worker maybe is some error connection. I think today I have new knowledge from Ajahn Yotin information, and I will try in the future. And I think I have Ajahn Yotin consultant for the COVID-19. I maybe can try to the correct data in COVID-19 in Surat Thani province. Hello.
Yes.
Hello.
Yes. Hello.
Hello.
Yes. Hello. You hear me?
We are listening to you.
Yeah,
we are listening.
Okay. Yes. Take it easy. Yeah, you hearing us?
ค่ะอาจารย์
Yes. The answer is, listen carefully. There are not many cases in Surat Thani, and nobody died.
Yes, yes, nobody die ค่ะอาจารย์
Yeah,
แต่
so
ไอ
that no, for mortality calculation, okay, listen carefully. For mortality calculation, you need to have some cases die because of coronavirus. Okay, if there is nobody, you cannot estimate anything. You need to change to cardiovascular, diabetes, or whatever cause of death. Okay.
Okay.
You may use United States data. You may use India data. You may use any other country where having death person and cause of death is coronavirus, but they do to use because
okay.
security purpose. You know, as I mentioned, look at this, look at this, look at this, look at my, sorry, understanding that people may hungry, and Dr. Farid may buy me some ayam, you know. Look at this, you know, case fatality rate, number of deaths because of COVID during that time period, number of COVID patients. If it is equal to 1 or greater than 1, it means that prevention potential and quality of care is not so good. So it reflects to the government strategies. Nobody want to tell you this, okay? At the same time, proportionate mortality, okay, number of deaths because COVID during that time period versus total number of deaths of cause, including COVID-19. So if it above 1, if it above 1 or greater than whatever number close to infinity, it means that prevention potential quality of care is so worsen. Okay? See, that dominated by COVID. At the same time, death to case ratio, number of COVID, okay, at time period versus number of new case reported. If it equal to 1 or you know greater than 1, it means that you know prevention potential quality of care whatever is worsened. It reflecting the country, you know, healthcare system, including with knowledge, attitude, and practice of civil population is not so good. Okay, not well. You know, refer to allow anybody who were a mathematician, statistician, or demographic or biostatistics to estimate their situation. As a result, this is why we were here. Okay, this is why we were here. Exchange our experiences and understanding the situation because of we are scientists and we want to estimate for our global, but they not allow us. I frankly speaking, if they allow us to estimate, they're supposed to release age and sex information, particularly the age group. But this time they just showing like graph, they showing pattern that is common. Okay. Yes.
Okay.
About noon time here in Thailand, and I believe that we have same time zone in Jakarta, in the Samarang, and what Surat Thani and Yatla, including some places. Yes.
Okay, there is another participant want to share your experience because
Yes.
we already arrived at 12 o'clock. It is time to have lunch.
Yes.
Okay, please.
Yeah, the question is, Professor Yotin, would you give example how to calculate probability of CA case? CA mean cancer, right? Yeah, the same formula that I provide. You just change COVID-19 to CA, and better CA can, if you were Thai, okay, CA information is at the Vital Statistic of Thailand, Ministry of Public Health. At the same time, we ASEAN country, we are using the same system we call health statistical system or something. Okay, you can download your vital statistic from Indonesian vital statistic report. Okay, CA is not so difficult to get data.
Okay, I think this discussion is very interesting, and maybe until evening we don't finish. Because estimating the mortality is very interesting, always interesting.
Yes.
Due to the time is limited, Ajan, maybe there is something from the audience want to ask something, you can post to the chat, and then I will send the question to Ajan Yotin directly. Okay, maybe we are already arrived at the end of this meeting. Thank you very much, Ajan Yotin. Thank you all participants. And also, I would like to invite Bu Ati to close this meeting.
Yes, please.
You can. Thank you very much, Ajan.
Yeah, thank you. Let's waiting for the closing ceremony.
Thank you.
Yeah. Waiting for the closing ceremony. Yes, please.
Let's have a photo. Let's have a photo. Everyone, open your video.
Okay.
Let's have a photo.
Hey, farmers.
Thank you very much to all participants. Yeah.
Bye.
Mungkin saya bisa menyambung dengan bahasa Indonesia ya. Di sini saya bisa kenal Ibu siapa? Omas, Ibu Rina, Ibu Sune ya, yang sebelumnya belum pernah ketemu ya. Ibu Rina, Ibu Omas, Ibu Imas tadi dari mana? Dari UI ya?
Ya Bu, saya mengajar di Fakultas Ekonomi dan Bisnis. Kita punya magister Ekonomi, Kependudukan, dan Ketenagakerjaan. Saya mengajar teknik demografi, Bu.
Oh begitu. Kalau Ibu ini, Ibu Rina sama Ibu siapa tadi? Enggak nambah ini. Ibu Rina dari mana, Bu?
Saya dari BKKBN Jawa Barat, Bu.
Oh, BKKBN Jawa Barat.
Iya, cuman saat ini saya sedang ambil sekolah di Mahidol, jadi studennya Ajan Yotin juga.
Oh iya, juga Pak Edi ya, tadi Pak Edi. Pak Edi apa Pak siapa ya? Dari BKKBN juga ya?
Pak Dedi.
Pak Dedi, ya.
Pak Dedi.
Bu Sune dari mana Bu Sune? Salam kenal semua ini.
Bu Sune from
Thailand.
From Thailand.
She does not speak bahasa Indonesia.
Oh iya. Thank you for your attendance in the meeting.
Yes, I can a lot of knowledge from this.
Yeah.
I know this seminar from Ajahn Yotin. Thank you, Ajahn, really much.
Yeah, you are very welcome. I need to take my wife to some places. Yeah, for some vacation. It's a holiday in Thailand. Everyone in Indonesia, okay, particularly Semarang, Surabaya, Jakarta.
After COVID, after COVID finish, we
shall
can
meet. We shall meet in Semarang.
Yeah.
You know, I plan to invite Dr. Farid to Bangkok to teach for National Council. Luckily, he could not come. That is under the plan, Farid. That is under the plan. I already talked to many persons that Farid will come to teach with me and Council, but COVID-19, nobody can go. Okay, I have to bring my wife for lunch and appreciate it. Okay.
Yes.
Thank you so much. Sawadee
Thank you.
Thank you. Yeah. Thank you. Kita foto bareng Pak Farid ya.
Foto bareng. Have a photo first, sir. Iya, dibikin panitia.
Foto, nah.
Gimana di kamera semua? Panitia Pak Farid gimana?
Panitia bikin Ya.
Panitia
where is
gimana?
Dr. Farid? Oh, okay.
Pak Farid. Yuk.
Who take photo? Who take photo?
Yeah.
Farma,
You should-
open your video, Farma.
Parma, Anissa,
We
Bella.
have 43 people, but only 10% show up.
Usually we meet to Prof Yotin again and again in Semarang, ya. But because of COVID, we meet in Zoom ini.
Now let's
Yes, say
smile,
hi.
smile, smile.
Yeah, sorry.
Smile, yes.
Please smile.
Yes.
One,
Say hi
two,
for
three.
Martha and Dean Fariha.
Okay aja.
Dr. Martha and Fariha, okay?
Okay, yeah. Thank you very much.
Okay, Sawadika. Thank you very much for all audience for this fruitful discussion. Okay, very good afternoon. Selamat siang semua. Terima kasih atas partisipasinya.
Bye-bye.
Yeah, bye-bye.
Izin live.
Ya.
Ya, monggo silakan Ibu.
Ya.
Silakan, terima kasih. Senang sekali
Sama-sama.
bisa ketemu.
Sama-sama, Ibu Bapak.